Today, I'd like to introduce a case of mine in which I had a very huge laceration of the Schneiderian membrane in a sinus lift surgery bilateral approach. But before to introduce the case, I'd like to talk briefly about the different surgical damage that we could make in the Schneiderian membrane during the maneuver of sinus lift procedure. Because we can do just a small damage of the endosteum. And the small damage of the endosteum usually is not so well diagnosed during the surgery, is not so well recognized. And this small damage could become a huge damage during the following phases, for example. Because usually we perform this damage during the osteotomy for the surgical approach to the membrane, when we are making the when we are designing the frame of the bony window. And then we could have another damage that is a membrane perforation. This is very famous kind of damage because there is a lot of literature about it. And the perforation severity and treatment depends of the dimension of the perforation and depends also in which phases of the surgery it could occur and even in which part of the sinus is happen. For example, if we are doing a trunk crestal approach and we create a perforation and we recognize the perforation, the best solution is to stop immediately the surgery and to wait 3 months. Later, we could repeat the surgery in a successful way. Vice versa, if we have a small perforation in the lateral approach, it depends in which part of the frame it could occur. Sometimes it's possible to manage in an easy way, sometimes not. But the last and the worst condition is the laceration. The laceration means that perforation is very large, and the laceration opens completely the visibility of the internal part of the sinus. And if we have the laceration at the beginning of the surgery, it's easy to manage because it's sufficient to stop immediately and to follow the same criteria that I told you a few minutes ago about the transcrestal approach. In the case in which the perforation occurs at the end of the sinus lift procedure, during the bone grafting or at the end of the bone grafting, maybe the situation is worse. And today, I'd like to introduce you a case in which I have a laceration just in this phase. The clinical case that I'm introducing now is for a patient that came in my office 5 years ago. She lost the upper premolars many years before, and a colleague of mine installed one implant in the premolar area, in the second premolar area. When I made the procedural study on CT/CB, I evaluated the dimension of the residual crestal bone that was very limited in height, because it was just 4 mm for the first premolar and 3 mm for the second molar. I decided to use the lateral approach. I decided to use the lateral approach in order to make a fast surgery because in the same surgical appointment, I have done a crestal approach in the opposite side in which the residual crestal bone was very thin, was almost 2 mm, no more. For this reason, I decided to do the crestal approach in the most severe area and to do the lateral approach here where the bone was thick enough to make in a fast way sinus lift and positioning to implants. And for this reason, my surgery was also fast. And now I like to make comments step by step about what happened in each phases in which I developed the surgery until to make a huge laceration, and then I like to show you the management of this laceration. Let's see the clinical case. We started designing the flap with the blade, the 15 blade. We start with the vertical releasing incision in the posterior area, just a little bit close to the mucogingival line. And then we perform one releasing incision even in the mesial aspect. At this time, I was using the manual flap elevator. Actually, I use just the piezoelectric elevator. That is definitely better because it's not necessary to make so huge force in damaging, that risk to damaging the soft tissue vascularity. But this time I didn't have any experience in it. So we raise the flap in order to make to have a huge visibility of the lateral wall of the sinus maxillar. Now you can see that we are doing the elevation even in posterior area, in which it should be better to go a little bit deeper with the blade in order to detach better than this the flap. Now we start to do the consuming technique. The consuming technique is the most predictable technique to preserve the Schneiderian membrane integrity, to preserve, to avoid the perforation. Because this technique is developed in order to reduce the thickness of the Buccal cortical bone. The techniques is done by the operator that make an osteoplasty maneuver and very fast, as you can see, using the cavitation effect. The device is set up in the lowest level of the irrigation in order to avoid to lose the particle. Another important consideration is the position of the tip of the suction that is in the distal part of the flap, and the assistant maintain this suction in contact with the bone in order to reduce the quantity of saline solution, in order to create the possibility to maintain all the debris, all the particles together, because we want, at the end of the surgery, to combine the autogenous bone with the xenographic material. For this reason, we collect the bone, and the best thing is to collect particle not too little. It's very important to combine the autogenous with the xenographic material, because we know that in the autogenous particle we have a lot of BMPs protein. We know the importance of the BMPs in order to induce, to activate the bone healing response. Now you can see that making this maneuver, we are reducing the thickness even in an area of the first molar. In this area, usually, we have the zygomatic process. For this reason, I prefer to avoid to open the sinus bony window in this area in order to avoid, to reduce the resistance of the skull. But in this case, was necessary to do that. And one advantage of the consuming technique is that we reduce the thickness of the lateral wall in order to make easy the osteotomy maneuver. And if the osteotomy maneuver is easy, we could preserve completely the integrity of the Schneiderian membrane. I have developed this technique many years ago. I have introduced this technique in Boston, in Quintessence Boston Congress in 2004, And from this time to now, I have a very good result. Not unfortunately in this surgery, and now I show you why. First of all, when we do this maneuver, it's necessary to reduce the bony window less than half millimeter, ideally 0203. Now you can see that we are very close just in the medial part. Okay, when we arrive at this stage, we have to consider that the bony window vertical dimension